So our last morning presenter is Dr. Lin Chang. She's my mentor and has been a member of the UCLA community for many years, since med school. Her clinical expertise is in the functional GI disorders, and she's a frequent speaker at national and international meetings. She's the co-director of the Gail and Gerald Oppenheimer Center for Neurobiology of Stress, and is the co-principal investigator of the center's NIH SCORE grant, which looks at the role of sex and stress on brain-gut mechanisms underlying IBS. She's also the program director for UCLA Fellowship Program and is a member of the Rome Foundation Board of Directors, as well as she previously served on the FDA GI Advisory Committee, which she also chaired. Before I welcome Lynn, just a quick note, we do have a Q&A section, so you can write some questions on the index cards that are provided on the table, and we'll collect them prior to that starting. Thanks.
Good morning, everyone. Thanks, Lynn. I also want to thank our organizers, Eric, Raman, and Bennett, for inviting me to speak here today. Actually, after I finished my fellowship, I went to Mayo Clinic for 1 year, and I met Dr. Alquist actually the first time, and I haven't seen him in a long time, but it's nice to be presenting in the same session. I actually don't have a disclosure slide, and I realized that in the book, it is missing 2 companies, which is Ironwood and Forest, so I just want to disclose that I've been on their advisory board. Okay, so I'm going to talk about defecation disorders, constipation and incontinence, diagnostic and therapeutic options. There's actually a lot to cover, but what I want to tell you is I put more slides and information just because I knew you would have a copy, but I won't be able to go over everything, but I'm happy to answer any questions during the Q&A or patient cases. I thought I'm going to start with chronic constipation, and I thought it would be good to start with an algorithm. And this is a fairly simple algorithm that was designed by the Rome Foundation. So when you have someone with chronic constipation, you start with, do they have symptoms? Usually it's some infrequent bowel movements or hard stools or straining, difficulty passing when they're not on a laxative, and you do a history and physical. Now, there was a study recently that was from UNC and I think also Iowa, basically stating that we don't do rectal exams anymore and we don't teach rectal exams. But for the gastroenterologists, it was higher than the primary care physicians, but it was still lousy. Now we all have these techniques like Cologuard and everything, but I would say for chronic constipation and fecal incontinence, you really should do a rectal exam, a digital rectal exam. So these are some nice images when you first do, I know you guys know how to do a rectal exam, but I know people aren't doing it as much, but when you first insert your finger, you're just really feeling the internal and external anal sphincter. You check for resting tone, you ask the patient to squeeze, but if you actually put your finger in a little further, at the tip of your finger, that's where you're going to feel the puborectalis muscle. That's contiguous with the external anal sphincter. It's under your voluntary control. It's attached from the pubic bone, wraps around like a sling, brings the rectum forward 90 degrees, and helps with continence. So you ask the patient to squeeze. That's, again, under their control, so it's a somatic muscle. And then really what you're trying to do for constipation is you ask them to bear down. You put one hand on their abdominal wall, and you ask them to bear down like they're going to the bathroom, sitting on a toilet, and you'll see that that puborectalis muscle and the external anal sphincter will relax, and that anorectal angle will increase, and that's what you're looking for. If you don't see that, or they have a contraction, which we call paradoxal pelvic floor contraction, that's a suggestion that they might have dyssynergia. Then you look for alarm signs. If they have alarm signs, then you really want to do more of a diagnostic evaluation. So these are alarm features for chronic constipation. It's basically new onset of symptoms over the age of 50. Also, if they have severe symptoms, never been investigated, rectal bleeding, unintentional weight loss, family history of organic disease, or a palpable abdominal mass, which we actually don't really see very often. But if you don't have it, then you can start thinking about other aspects. The first thing you always look for is drugs. Are they on a constipating drug? And that's particularly the case of the elderly. And if they have a drug that's temporally related to their constipation, you stop it. If they get better, then they have drug-induced constipation. So for chronic constipation, we use the Rome criteria. And so the thing to remember is when someone says, I'm constipated, you have to ask them, well, what do you mean by constipation? So there's 6 signs or symptoms, and if they have at least 2 of these, then they meet the criteria for functional or chronic constipation. So some patients will just have straining and hard stools, but they're going every day. They still have constipation. So when you think of constipation or primary functional constipation, so not related to a structural lesion, not related to drugs, these are the three big entities. Slow transit constipation, so stool moves through the colon slower. Normal transit would actually, the stool moves normally, but they feel constipated. So some people call it sensory constipation. They don't feel like they're empty after they go to the bathroom. And then a defecation disorder like rectal prolapse, rectocele, or dysenergic defecation. Okay, I'm going to give you the ACG 2014, so you'll have this, their task force where they gave a recommendation on quality of evidence for these different types of treatments. So we have fiber osmotic laxatives, stimulant laxatives, and 5-HT4 agonists. On the far right column, you can see the quality of evidence based on studies, and they had to be randomized controlled trials. And then you'll see the recommendation. And strong means that a recommendation that can apply to most patients in most circumstances, and even if we got further evidence, it was probably not going to change the outcome. So even though you might have low to high quality of evidence, the recommendation is strong because they don't think even further or higher quality studies is going to change. So all of them were recommended. And then also for the pro-secretory agents, linaclotide, lubiprostone, biofeedback, and probiotics, you can see the recommendation. A lot of people who do biofeedback think it was unfairly given a weak recommendation, that there is more evidence to suggest that it's efficacious, which I agree with. Probiotics is weak. Now, I'm just going to give you just one practical slide that you don't have in your book, because I realized when I looked over my slides, I didn't really have a practical approach. But if you have mild constipation symptoms, then just dietary intervention or fiber is fine. If it's mild to moderate, usually that's when you move to osmotic laxatives and lubiprostone. I don't think lubiprostone is as strong as linaclotide, so I usually use linaclotide when their symptoms are a little bit more severe. You go to stimulant laxatives if the osmotic laxatives don't work because they're associated with cramping. But you can use them. It's a myth and misconception now that if you use that, you're going to have more neuronal damage, and no one's shown that that's the case. I use prucalopride sometimes. It's a 5-HT4 agonist. I can tell you a little bit about it later. It's not approved in the United States. You can get it other places, and I think it's effective because it's a prokinetic agent. I usually use a single agent, but then I have to augment because I don't want to go to higher doses. And sometimes it's helpful to use more than one agent if someone has more severe symptoms. Bisacodyl is a good drug, and I'll show you a little bit of data, but I use it more as a rescue medicine. If you look at any clinical trial for constipation, whether it's IBS with constipation or chronic constipation, bisacodyl is always the rescue drug because it usually will deliver. It's just not a great drug to use on a daily basis. And if it's they have refractory constipation, that's when you want to start looking for a defecatory disorder. I just want to show you this study because a lot of people don't talk about it, but this is actually a high-quality study where they use bisacodyl at 10 milligrams per day. Each tablet's 5 milligrams. And they showed for chronic constipation, it was actually effective. But again, you can use it, but I find that patients will keep upping the dose. And as I said, it's a good rescue medicine. This is the chloride channels in the gut, so the lumen's on the top, the basolateral surface is on the bottom. So we have multiple chloride channels. The CFTR is our primary channel, and that's how linaclotide works. The CLC2 is a secondary channel, and that's how lubiprostone works by increasing electrolyte and water secretion and causing rapid transit. This is the data on lubiprostone. The primary outcome measure for chronic constipation studies is usually spontaneous bowel movements, the frequency, and sometimes complete spontaneous bowel movements. So they may go, but do they feel empty after they've gone? So this is the lubiprostone data. It's 8 micrograms, 24 micrograms. You can use either dose for chronic constipation. But take it with food because it causes nausea. So linaclotide, this is the data for chronic constipation. It's a high-quality study. As you can see, this is a hard endpoint to reach. So the active drug and the placebo, the response rates are on the lower side. It's effective. The primary side effect is actually diarrhea. So you can use it at the lower dose, 145 micrograms. Once a day. For IBS constipation, use the higher dose, but honestly, I usually use the lower dose, and then I move up to the higher dose if they don't have diarrhea or it's not efficacious at the lower dose, whether it's IBS-C or chronic constipation. This is the meta-analysis on prucalopride. I really do think it's a good agent. It's like tegasterod, except it's a pure agonist instead of a partial agonist, and it has not been associated with cardiovascular side effects. It's available in many countries in the world, but not in the United States because they never sought FDA approval. But I do think it's a good agent for some of these patients who need more of a prokinetic effect, that these other agents don't work. Also, there's some evidence that these prokinetic agents help upper gut symptoms, and a lot of these constipation patients also have nausea or gastric slowing, and so I think that this can be helpful. There's a little bit of data on probiotics, and patients ask about probiotics a lot. You can see that the first probiotic that's been studied in constipation is the probiotic that's in the yogurt that everybody uses, where you usually have to take 2 yogurts a day to have some efficacy. And they have a couple other ones. There are some patients that have some benefit, but in general, the evidence is weak for probiotics helping chronic constipation. Okay, so say you have a patient, they have constipation, you did all the usual measures, they didn't get better, so now you're thinking, okay, this is refractory constipation or difficult defecation, and what are you gonna do? So they meet the criteria for functional constipation, but now you're gonna start thinking, I need to do some further physiologic testing to determine what's the actual driving factor of their constipation. So we order anorectal manometry. I didn't have any pictures for high resolution, but what you're looking for typically is dyssynergia, and what you're looking for is that they squeeze their anal sphincter and puborectalis muscle instead of relaxing it when you ask them to bear down, or it doesn't contract, but it doesn't fully relax, and they don't have enough rectal propulsion and contraction to override that anal sphincter tone and have an evacuation. What we do a lot is the balloon expulsion test, and I think this is a really good screening test. So you put a deflated balloon, you fill it with 50 or 60 milliliters of water, and you put the patient, we put them in a private bathroom because it's kind of hard to sit there and watch them, but you put them in the bathroom. It has a catheter, so they hold on to it, and you give them a minute, and in some cases you give them 2 minutes because you can pick up a few more patients, and you give them a chance to evacuate the balloon. So it simulates stool. So if it's abnormal, it's a good screening test that they have a defecatory disorder, typically dyssynergic defecation. So if a patient, you do anorectal manometry and rectal balloon expulsion, which you see here in the right, in the red square. So if they're both normal and you don't think the patient has a defecatory disorder, then you can do a colon transit study to see if they have slow transit constipation. If you think that's going to change management, a lot of the patients want to know. Sometimes it doesn't change management unless you're thinking about, colectomy, which is really rare. But say they're both abnormal, then really the patient has a functional defecation disorder. Say one's positive, one's negative, you're not sure, you can do an MR defecogram, or just the basic barium defecography, just to confirm what they have. This is an MRI defecogram. Then what you should do is, if you have a functional defecation disorder, you might want to ask, is it combined with slow transit constipation? Because they could have coexistent causes, and you could think about doing a colon transit study. But in general, if they have a fecal, if they have a defecatory disorder, you really have to treat it first, because the defecatory disorder can cause slow transit constipation, and you don't really know if they have true slow colon transit unless you treat the defecatory problem. This is a colon transit study, but I'm going to skip going through that. I just want to show you about the biofeedback. We actually have controlled trials. This is important to remember. This is laxatives versus biofeedback. Because you're thinking, even if they have a defecatory disorder, if I just give them enough laxatives, will they go to the bathroom? And in general, about 20 to 30% of people with dyssynergic defecation will have a good response to laxatives. So you're going to miss a lot of people that if you keep giving them laxatives, they're still not going to have a satisfactory bowel movement because you're not really treating the problem, which is dyssynergic defecation. And biofeedback is much better for that. If you look at biofeedback centers of excellence, it's about 70% success rate. They actually did a study where they compared biofeedback to sham biofeedback and standard, which is diet, trying to give them some just education. And again, biofeedback was better than these 2 other treatment interventions. So in summary, for the chronic constipation part of the talk, the primary causes include slow transit constipation, normal transit constipation. They feel constipated, but their transit time isn't slow, a defecatory disorder, and then you don't want to forget about IBS with constipation, which means they have pain associated with a constipation. You can have some pain with chronic constipation, but you usually don't have pain unless they haven't gone for many days. And then if they go to the bathroom, they feel better. IBS patients, you can get their bowels moving, they still feel pain and bloating. Rectal exam and physiologic testing can help to determine the cause. The only FDA-approved treatments for chronic idiopathic constipation are lubiprostone and linaclotide, but you can use these other modalities. And you want to determine the presence of pelvic floor dyssynergia, particularly in refractory patients, because the best treatment is really biofeedback. So let me move to fecal incontinence. This is pretty common, as you can see, and definitely as you get older in the nursing home patients. It's more in women, but in the elderly, particularly nursing home, it's more common in men. And you can see the risk factors on the right. Okay, so there's 3 types of fecal incontinence. There's passive incontinence. They don't feel the urge. They just pass stool. You have to think that their internal anal sphincter, which gives most of their resting tone, is weak. Urge incontinence means they have the urge, but they can't make it to the bathroom in time. Often that's the external anal sphincter that's weak because they can't squeeze it strong enough or prolonged enough to have enough time to make it to the bathroom. And fecal seepage is just where they're not really having a stool come out, but they have a little bit of liquid. Sometimes it's mucus, but it's usually a little bit of stool. These are the associations that you can look at in the book for passive incontinence, urge incontinence, and fecal seepage. These are the different diagnostic evaluation studies. In general, we do digital rectal examination, and we do anal rectal manometry and anal ultrasound. We don't usually do many of the other types of diagnostic tests. The thing to remember, like I said about passive incontinence, if they have no urge, they don't feel it, but you can have someone like diabetes who just has decreased sensation. Sometimes people are told to put a little cotton swab in their bottom just to hold any leakage. And the other thing to remember is functional fecal incontinence, and so that's people with overflow incontinence. And then you do a rectal exam, not just for anal tone pressure, but also to see if they have dyssynergic defecation. Because if they can't evacuate stool, they'll build up a lot of stool, it'll get hard, and then if you distend the rectum, you're going to cause the internal anal sphincter to relax, and then you're going to start getting seepage because you're giving them laxatives, and they'll really have overflow incontinence and not true classic fecal incontinence. These are just the different diagnostic tests and the yield of them that you can look at. This is I don't know if you can see it, but you can probably see in your books. This was an algorithm that just came out by Adil Barusha and Satish Rao in Gastro. So if you have some of the fecal incontinence, you do a clinical evaluation. You really try these simple measures like diet and anti-diarrheal agents, because many of these patients will really have watery stools and frequent bowel movements. And if you just treat that, they won't have much incontinence. And I would really tell you to think about that first. Now, if they have persistent fecal incontinence, then you would want to do an anal rectal manometry. And if they have a weak sphincter, if you think there's some disruption, you may want to do an anal ultrasound. If they have some capacity to squeeze and you can teach them to strengthen it, just like you're strengthening your bicep muscles, then you want to do biofeedback. But if they don't have that capacity, you have to think of other treatments like the dextranomer that I'm going to talk about, or sacral nerve stimulation, or even surgery if that's indicated. You do a balloon expulsion test because you're looking for really that they have constipation and they really have overflow incontinence. So these are the different treatment options, from conservative therapies, something more moderate, and to conservative to surgical therapies. So I also just summarized the medical management for you to look at. So we have dietary modifications. If you reduce the carbohydrates, which are highly fermentable, you can sometimes make the stool less loose, less frequent bowel movements, and that can help their incontinence. But conservative treatments like diet and these kind of modalities, it's successful in 25%, but you want to try to get those 25% before moving further. Some people use incontinence pads, of course. If you ask someone if they use a pad, usually their incontinence is worse. Antidiarrheal agents, I think, are very effective because many of these patients have frequent bowel movements that are loose, and they only have incontinence when they're loose. So if you can improve that, then you don't really have to proceed that much further. Enemas, like we saw a patient yesterday, he uses an enema in the morning just to get it out of the way, and he's a teacher, and then he doesn't have to really worry about incontinence later in the day. And then anorectal biofeedback is useful. These are the pharmacologic treatments, and as you can see, they're mainly treatments that are going to slow down colonic motility, make the stool more formed, and that can help fecal incontinence. I thought this was kind of interesting. There's a group that does a lot of anorectal biofeedback for fecal incontinence, and what he was telling me, and this makes it so tough because we really don't remember how we toilet trained when we were 2 or 3, but what you have to do for fecal incontinence is you have to keep the puborectalis and the anal sphincter tight, but you want to have your abdominal wall muscles relaxed. Because usually what you do is you squeeze everything. And that's the problem with dysynergic defecation. You want to squeeze your abdominal wall muscles, but you want to relax your sphincter. And it's kind of hard to do that. There's a little bit difficult coordination. So really the patient is not supposed to rush to the bathroom, which of course we're all going to do anyways, because what they do is they start squeezing their abdominal wall muscles, and they actually can provoke more incontinence. But actually for them to sit on the toilet, do a few Kegels, try to evacuate what they have in the rectum can be helpful before they get up from the toilet. So biofeedback has been shown to be efficacious for fecal incontinence. This study compared those Kegel exercises with biofeedback, where they're looking at a screen so they see what they're doing with their anal sphincter muscles. And then they compared to just Kegel exercises by themselves, and the Kegel exercises by themselves was not as effective as combining it with biofeedback. So dextranomur is an injectable. The primary outcome was decreasing the number of incontinence episodes by 50%. That's actually not a validated endpoint, but people do use that, and it showed that it was efficacious in this study, and it got FDA approved. There has been a follow-up study where they compared it to biofeedback, and basically they were equivocal. I mean, they were similar. Sacral nerve stimulation. This has been FDA approved for fecal incontinence. So you have a temporary nerve stimulator, and they usually keep it in for about 3 weeks. And if the patient responds, then they implant one. And so this can be efficacious for fecal incontinence. For constipation, it's not quite as clear. The problem with these studies is you don't have a controlled arm. So you're just following the sacral nerve stimulation. And we know for any one-arm study, the efficacy is always going to be better. I found this study that was just published, and what they wanted to do is look at sacral nerve stimulation for fecal incontinence with people that had that stimulator for at least 5 years, so you know the long-term outcome. This is 10 European studies, and you can see that they did temporary testing in 400 subjects. There were some non-responders, about a third. They didn't respond. They didn't get the actually permanent device. And then they put the stimulator in 67%, two-thirds. It was successfully implanted in about 58%, and then they had some dropouts. But overall, if you look at the intention to treat, 50% of them will say, I had a 50% improvement in my symptoms, and a third of them will have total continence on these 5 years. The adverse events is that you did have minor complications in some of the patients. It was due to the device in most of those subjects. They had pain as the most common adverse event, and sometimes you had to remove or reposition it or re-implant it. This is surgical management, which we don't do very often or send patients to. You can do sphincteroplasty, particularly in women who've had a lot of injury during childbirth and they've disrupted their sphincter. This might be something that would be useful for them. So to summarize for fecal incontinence is not rare. Patients don't always share that information, and you actually have to ask them, particularly if they have diarrhea. Fecal incontinence is not the same as diarrhea, although I will say that a lot of the times when you treat the diarrhea, the fecal incontinence gets better. And it can dramatically reduce the quality of life for the patients. And it's important to recognize the risk factors for fecal incontinence. History and physical examination are really important. You want to refer to a specialist when you're considering specialized testing. Conservative approaches, remember just thinking about bulking the stool. Starting slow, fiber absorbs water. It can make the stools less loose, maybe not going multiple times, maybe they're going less times. That's something to think about. Antidiarrheal agents and biofeedback for those patients who have some retained external anal sphincter function so they can actually strengthen the sphincter. And then you think about dextranomer injection, sacral nerve stimulation surgery as additional treatments in select patients with fecal incontinence. So thank you very much for your attention.